Good evening, Molweni, ladies and gentlemen, doctors, medical professionals that have joined us tonight. Apologies once again for the late start. As we mentioned, we were scheduled to start at 7 o'clock. I'd also like to welcome our live streaming guest. Good evening, everyone. My name is Sandile Sihlaba. I'm the Group Chief Marketing Officer from Lancet Laboratories, based at head office in Johannesburg. It is a privilege and an honor to have this opportunity to direct proceedings as well as just celebrate this milestone achievement in terms of Lancet Laboratories. I delayed even with the technical gremlins that we had because today is about the team that you are familiar with, our Eastern Cape team and specifically the Mthatha team. So if I may kindly just call the team led by Dr. Trisha Mudley to the front of the podium, Nobisa Gule and Tobile Zondo. Thank you, thank you. You may clap. So why I want this team in front of you, because as I mentioned, I'm from the Eiffel Tower in Johannesburg and I'm just a visitor. But this is the dynamic team that you are familiar with, that we are thankful towards and to for the success and the service and the excellent output that as a region in the Eastern Cape, Mthatha specifically, that Lancet has been able to deliver. This, as I mentioned, is a milestone occasion for us in the sense that firstly, we listened. I think our presence started 5 years ago in Mthatha, and there were pleas and calls to Sisnwabisa, and then you met Tobile as well, and you said, Tobile, but why? We know that you do these things in the other provinces, why not here? So there was some logistics we had needed to sort out, but we have listened. And hence this milestone today is that we are hosting our very first ever CPD in Mthatha. I think we all deserve a round of applause for that. The second milestone I'd just like to share is that over and above that, in all the other provinces, and I think this is a brag factor for Mthatha in the Eastern Cape province, is that this is the first time we're hosting a CPD where we have a live presence. And thank you all for your precious time this evening in your busy schedules, as well as a streaming session. I think the last count from my team in Johannesburg was that we had 15 guests streaming. I can't confirm from which provinces. So I think that is also quite an achievement from Mthatha to host the first hybrid CPD. A round of applause, please. So the team in front of you, if I can just hand over to them now for the formalities. The team in front of you is led by our regional pathologist, Dr. Trisha Mudley. I think when I introduce her, when she does her talk, I'll give a bit more information of Dr. Trisha Mudley. She is a resident of the Eastern Cape now. She's given up her life in Johannesburg and is part of the family in this lovely province. It's led by Dr. Trisha Mudley. In the middle is someone that is very familiar and someone that is very diligent and someone that is customer-centric, doctor-centric, and is really a star within our team, and now has the daunting task of being our marketing officer for the entire Eastern Cape province. So we've borrowed her from Mthatha, but she will come and visit, she will see you, and she'll maintain those high standards that you are familiar with. Her name is Tobile Zondo. And on the left is what I call, because she is so humble and a star behind the scenes now, but many of you are familiar with her because she started this journey for us in Mthatha. She obviously assumed multiple roles. She was doing marketing, she was doing management behind the scenes in the lab, overseeing all operations, and as a practice, we are very grateful to the dedication that she shows and she continues to show. Over and above all of us, she was the most excited for today, which shows the passion and the dedication. And I'd like to also introduce Nobisa Gule. Nobisa, what is your job spec, or what is your title, if there is one? Because She's the manager of everything, so she oversees everything in Mthatha to make sure that everything work well. But ladies and gentlemen, we did start late. I don't want to bore you. As mentioned, I'll be directing proceedings for tonight. Just some house rules. I think they should be on your tables, Wi-Fi passcodes, and then to my left for any smokers. Opening drinks have been served and starters as well. But I think today, enjoy yourselves. This is for you. And on behalf of the executive board, the marketing board that I'm part of, top management at Lancet Laboratories Group, would like to really, really thank you for the support as doctors in Mthatha and in Eastern Cape. Watch this space. We are here. As mentioned, we have a footprint in Mthatha. We have a footprint in East London at the Royal Buffalo Specialist Hospital. And on Saturday, we were quite privileged to be in the presence of our Honourable Premier and MEC of Health in the opening of the grand opening of the Royal Buffalo Specialist Hospital. Many influential individuals in the Eastern Cape were quite pleased that Lancet Laboratories has made the bold step to come into the province and contribute towards better healthcare and assisting the community. So we're quite excited. Enjoy tonight, but just for formality's sake and just to, as a symbol for this great milestone of today, I'd like the team just to cut the ribbon, and if we can just clap for the occasion. Thank you. Thank you. Okay. A very experienced technical team at the back, and like I said, this is quite interesting as this is the first ever hybrid session. The first speaker that we have that I will introduce is based in Johannesburg at our Lancet Richmond main lab head office. Her name is Dr. Nicole Holland, and I'd like to read her introduction before she presents her talk to you. Dr. Nicole Holland has been working in the field of hematology for more than 20 years. She was drawn to the discipline for its blend of genetics, science, and medicine, and her greatest satisfaction comes from cracking a difficult case. She describes her work at Lancet Laboratories as varied and enriching, with involvement in the coagulation, flow cytometry, general and special hematology, molecular, and hematolymphoid histology branches of hematology. She joined Lancet in 2010 and has been a partner in the practice from 2018. Dr. Holland, I think I cannot speak to you, but I think online you are ready to rock and roll. Thank you very much.
Hi, good evening, everyone. Just want to get acknowledgement that you can hear me, that I'm live.
Yes, Doc, we can hear you.
Okay, great. I'm going to start presenting my presentation. Let me just see, it was up. I'm looking for my screen now. Is my screen up with you? Can you see my screen?
Yes, we can see your screen and yourself.
Okay, great, thanks. So tonight I'm going to discuss an approach to polycythemia. Polycythemia is a fairly common laboratory finding, and there are multiple different causes that can result in polycythemia. So I'd like to give a fairly broad discussion and approach to finding this raised hemoglobin level. And I'm going to start this with a case study. Just hoping to go to the next slide. Help me, next slide. So I'm just moving my slide one. Just need. We're just trying to get my next slide to come through. Yep. The patient is a 74-year-old man who went to his GP with no significant real current complaints. It was more for a general checkup. He did have underlying chronic conditions, and these are important to remember. He was a known hypertensive, he had hypercholesterolemia, and he was on medication for this, an ACE inhibitor and a statin and ecotrin. So both the underlying conditions and the medication are important in the context of investigating a polycythemia. He had no history of smoking and was a social drinker, but moderate. And examination showed a slightly ruddy complexion, but nothing very dramatic. Certainly no splenomegaly. And a full blood count was done as part of the routine checkup. And there were a number of flags that came up on this FBC. The hemoglobin level, 16.8, is within the normal range for a man. However, put into the context of this, we have got a low mean cell volume of 72. So these cells are quite microcytic and hyperchromic. So that though the hemoglobin is very maintained, these are small and pale cells. And you can see the red cell count is raised. His hematocrit is actually 0.53. In addition to the abnormal red cell indices, he had a thrombocytosis with a platelet count of 699 and a neutrophilia. So there were multiple abnormalities on this, and this is a fairly characteristic blood form. Additional testing was performed to try and get to the bottom of what was going on with this gentleman. He had a normal U&E and dipsticks that were done at the same time as the FBC. Pulse oximetry was performed, a simple pulse snip to determine what his oxygen saturation was. Everyone seems to have pulse oximeters now with post-COVID, so very, very easy thing to measure. And his saturations were normal and had a normal chest X-ray and abdominal sonar. But here it became interesting. An erythropoietin level was done, which is the hormone that stimulates red cell production, and this was low. So this wasn't an appropriate response to a raised erythropoietin. In fact, erythropoietin was suppressed. And that is a red flag for the fact that this might be a clonal or autonomous overproduction of red cells. And this was further confirmed with PCR testing of the specific genetic abnormality that's very commonly found in the malignant form of polycythemia vera. And indeed, this was positive. A bone marrow was performed, which we saw, and cytogenetics, which showed that there was no obvious macroscopic genetic abnormality on karyotyping. I know bone marrows aren't everyone's cup of tea, but so I get excited by them, but that's because I'm a hematologist. But I can tell you, and you'll have to believe me, that this is a very, very cellular bone marrow with lots of hemopoietic material present. And these big cells over here are the megakaryocytes, which are the platelet precursors. So they're prominent as well in this specimen. Here's an up-close look at a megakaryocyte, and here you can see all these platelets that are budding off this is like the mothership, and these are the little platelets that are budding off after they've been produced from the mega. It's got characteristic features that we can see in myeloproliferative neoplasms. It's a big cell. It's got little cells traveling through it, which is something called emperipoiesis. These are neutrophils that are traveling through the cytoplasm, which is a feature more commonly seen in clonal myeloid conditions. We also did an iron stain on the marrow. So bone marrow aspirates can be a useful way in which to assess iron stores. And normally iron stains blue, and you can see that there's no blue staining on these particles, and this patient was iron deficient. The trophine biopsy, which is the biopsy we were taken, showed very much the same features. A marrow that's very, very cellular, as expected from the full blood count, with lots of megakaryocytes, the platelet precursors, and lots of red cell and white cell precursors. So it was a busy marrow, very, very characteristic of a polycythemia vera. So final diagnosis indeed was polycythemia vera with an associated iron deficiency. And interestingly, at least about 80% of P. veras are iron deficient. So absent irons is common in P. veras for a number of reasons. One, because there's so many, there's such an increase in production of red cells that you utilize all the iron. And number two, they're predisposed to easy bleeding. So they can bleed and become iron deficient from that point of view. So this case seems very straightforward and very easy, but not all cases of polycythemia are straightforward. And this is where I'm going to try and give an approach to managing someone or investigating someone with a raised red cell count and hemoglobin level. So just definitions, which you have, what exactly is polycythemia? So the name from Latin gives it away. Poly, multiple, cy, which is the reference to a cell in the blood. So multiple cells in the blood. Classically, it's a myeloproliferative it's a disorder characterized by lots of red cells. And the definition is an abnormally increased peripheral blood hemoglobin level and or hematocrit. So that's how you would define it. Now, according to the WHO in 2016, they redefined the cutoffs for polycythemia, for a man, the cutoff being 16.5 for hemoglobin level and a woman 16. So this is a slight change from what it was, quite a significant change from what it was, to try and capture patients who are on the borderline polycythemia range to get them early. So if you can look at our patient, very clearly did fit into classic polycythemic definition, because his hemoglobin level was 16.8, his hematocrit was 0.53, so clearly polycythemic, though his HB was within the normal range for a gentleman at altitude of his age. So important to remember that these are the cutoffs for polycythemia. So just a little bit of an outline of what I'm going to cover in this talk. It's going to be a bit of a mechanistic approach to polycythemia. So the whys and hows, and then in those particular mechanisms, what are the individual causes and how to investigate more fully. Then more detail on malignant or clonal polycythemia vera, little about the course and the treatment. And then briefly at the end, the management of secondary causes of erythrocytosis. So please take notes. I'm really keen to answer any questions that anyone might have at the end. So please take any notes of anything that you would like to discuss with me a little bit further. Okay, so important concepts are relative versus absolute polycythemia. So the first big category would be something that's relative, and then the other would be real or absolute polycythemia. And that's got two subcategories really, which is both primary and secondary. I'm going to discuss relative polycythemia first. Now this is a cartoon of a test tube containing blood. Once we spin blood down, the red cells and white cells settle at the bottom and the plasma at the top. Now you can see that would be a normal situation, but there are situations in which the plasma volume actually depletes, but the red cell mass, as you can see, is identical. However, hemoglobin is a concentration, so relatively the hemoglobin concentration will go up, as will the hematocrit, but this doesn't reflect an increase in the red cell mass. And so what conditions can result in a relative polycythemia? So obvious ones, like a patient who's presenting with vomiting and diarrhea with dehydration. And this is particularly apparent in young children, a little bit of losses, and they can become quite polycythemic. So a patient like that will come with a raised hemoglobin level, and usually after rehydration, that settles without any problems. An important group to remember are patients on diuretics. So the elderly hypertensive patient who's on a diuretic could have a relative polycythemia. And that's why I said when I was chatting about my patient in the beginning that it was very important to note what drugs he was on, his underlying medical conditions, because they are relevant. And laxative use, people sometimes don't give the history of using laxatives, so it's something that needs to be inquired about. And anorexic patients with anorexia nervosa are typically volume depleted, and smokers as well. Smokers become polycythemic for a variety of reasons. This is certainly something Dr. Trish Moodley will discuss a little bit further in her presentation, but smokers are volume depleted as well. Then there's an entity which is a little bit controversial, which is called stress polycythemia or Gijsbox polycythemia. And it was characteristically a woman who was described as extremely anxious, and they defined an entity of relative polycythemia in this setting. However, whether it's a real entity is uncertain, because a lot of these patients actually are hypertensives on medication and smokers. So it's probably more related to the other than being a unique standalone entity. So how do you diagnose this? It's really going to be predominantly by looking at the clinical picture. Looking at the history, that may be obvious, as we've alluded to. but it may be more subtle and require further questioning. Examination with loss of skin turgor or complaints of orthostatic hypotension or measuring sitting and standing blood pressure would give a fair idea that the person may be dehydrated or volume depleted. And looking at urea versus creatinines to determine if there's evidence of dehydration. Do remember that in elderly patients, certain of these signs can be quite difficult. Certainly loss of skin turgor, when you've got reduced elasticity of skin, can be difficult to assess in an elderly patient. Historically, radioactive studies used to be done with using radio-labeled red cells and human albumin to try and determine the actual red cell mass and plasma cell volume. But largely these are not performed, certainly not in routine practice, and really rely on specialist physiologists to look at this, and usually are not necessary to assess a polycythemia. Now, that's the relative out of the way. The bigger category of absolute polycythemia I'm going to discuss now. And if you go back to our test tubes, you can see the situation here. This would be a normal situation. Here, the red cell mass has actively increased. We've got more red cells. And the two major categories of absolute polycythemia are primary, in which this red cell production is independent of any signal. The body is just doing its own thing and not listening to anyone telling it to stop, as opposed to secondary, where this is appropriate and expected. The body is using erythropoietin as its signal, and the red cell erythron is obeying and producing more of the same. The important thing about the primary situation, it's the result of a mutation. So that mutation can be congenital, in other words, within the germline of the patient, present in all cells, or it can be somatic and acquired. For instance, the situation with a clonal or malignant polycythemia vera. Not all the cells will have the abnormal mutation, but the hemopoietic precursors, the erythroid precursor, will acquire it and produce more clonal cells. Now, these mutations are typically those that affect pathways with production of erythropoietin, makes a lot of sense, or with the signaling of the red cell hormone. So erythropoietin, as you know, is the hormone that's responsible for stimulating red cell production. It's the red cell growth factor, by and large. And it's produced largely by the kidney. Renal cells produce about 90% of all body EPO, and the triggers for the release are anemia, resulting in tissue hypoxia, general body hypoxia, and impaired renal oxygen delivery. So obviously, when the patient is anemic, the oxygen carrying capacity of the blood is depleted, and that will make the tissue in the kidney relatively hypoxic, and there will be a stimulation for EPO to be produced by lots of the renal cells. You can see this in this little graphic over here. In normal situations, they're going to be not much production of EPO or standard baseline production, while this will increase in the situation where a patient is hypoxic. And EPO, once released, will travel through the blood and act on the erythron, the erythroid progenitor cells, and it will work via the erythropoietin receptor, which has got kinase domains attached, and the JAK-STAT signaling pathway will result in increased transcription of growth factor genes and proteins that are involved in cell cycle and increased cell production. So simply, you'll have a stimulus resulting in more EPO. EPO will fire the receptors. The receptors will cause more cell cycling and more cell signaling and growth of the erythroid cells, or the precursor red blood cells in the bone marrow. Okay, so talking about primary polycythemia, the congenital versions. These are two examples which are slightly more common. As I said, they are the result of mutations, and the mutations are involved in that hypoxia sensing pathway, and also in the firing and erythropoietin receptors. So Shuvash polycythemia was a condition. Sorry, go back. which was primarily described in an area of Russia called Shuvashia. And they're homozygote patients who are homozygous for a mutation in the von Hippel-Lindau protein or gene, were noted to be very polycythemic, to have certain other features associated with an increased red cell mass. And what was found is that this gene is involved with the sensing of hypoxia, or the relative awareness of the body to hypoxia, because the gene affects levels of hypoxia-inducible factors. The HIFs are what's directly responsible for stimulating erythropoietin transcription. And if the VHL protein isn't around, what actually happens is that the hypoxia-inducible factors, more of them are released and more red cells are produced. So if there's a mutation in VHL, more HIFs are around because they aren't destroyed, and more EPO is created by the red cells, which obviously results in an increased red cell mass. So it is something to, when you're looking at a patient, important to take into account the age and also a family history of, oh, my dad or my aunt or someone else in the family had polycythemia, or in the area from which they come. Then another mutation which is present in the germline setting is erythropoietin receptor mutations. And an example of such a disorder is primary familial and congenital polycythemia, which is an autosomal dominant condition, which is characterized by an abnormality of the erythropoietin receptor and results in polycythemia in the patients who are affected. And this, you're more likely to get quite a strong family history because it's autosomal dominant. There are NGS and next generation sequencing panels that can look at a whole variety of different mutations that are seen in the setting of polycythemia. Okay, now I'm going to talk about the acquired primary. So we've dealt with the congenital primary, where the mutation was germline. This is the acquired primary, when the mutation occurs within the cells of the bone marrow and the cells of the erythroid lineage specifically. It is a clonal disorder. It's a malignant condition, and it is one of the group of myeloproliferative neoplasms. So it's characterized by proliferation of cells. The red cell production occurs independent of any mechanisms that would normally regulate erythropoiesis. And the underlying genetic abnormality, which was identified, is an abnormality in the JAK2 gene. And it's in 97% of all P. veras, it's a valine to phenylalanine mutation on exon 14, which results in this phenotype. The small number of remaining P. vera cases, there are other JAK2 mutations, predominantly in exon 12, that are involved. And the proliferation, remember, is not only in the erythroid lineage, but also in granular poiesis and in megakaryocytes. So also the neutrophil precursors and in the platelet precursor cells, because it's a hemopoietic stem cell that actually bears this mutation. And when I was discussing our patient in the beginning, we noted that he was not only polycythemic, but he also had a raised platelet count and a raised neutrophil count. And that's a very characteristic picture of a clonal polycythemia, and something that you can look at quite easily on the FBC and will increase your degree of suspicion. Okay, this is the situation in polycythemia vera. Normally, erythropoietin will stimulate its receptor. JAK2 will then cause transcription and push the cells into cycle, and there's proper negative feedbacks. What happens in the case of P. vera is that there's constitutively activated JAK2. So it's always firing, even in the absence of erythropoietin binding. And it's just saying, make more, make more. So there's always a constant production of more red cells. And that production doesn't have a negative feedback. So it occurs autonomously. And it's really a rogue pathway. So what are the clinical features of P. vera? Now, a lot of them will be features that you would get with hyperviscosity for any cause of polycythemia. And features that are associated with hyperviscosity include headache, a visual disturbance, paresthesias. People complain of thinking very slowly, not being able to think. So if you have a patient, you find a hemoglobin level that's raised, important to go back to the patients and say, you know, are you struggling with headache? Do you have any other, are you finding it difficult to think? Those sort of questions would be important. They might also complain of chest and abdominal pain, weakness and muscle ache. Those are all related to the increased red cell mass and the hyperviscosity of the blood. Now, very, very importantly, are the symptoms of thrombosis or bleeding, or the consequences of this raised red cell mass. And this is often what causes the morbidity and mortality in the setting of polycythemia vera. The thrombosis can typically be at an unusual site. So splanchnic vein thrombosis is common. That would be a portal, hepatic vein, mesenteric veins. Those are the sites that are frequently targeted in polycythemia vera. And the thrombosis can be both arterial and venous. The other signs that are related would be those of an increased metabolic rate. So any patient with a myeloproliferative neoplasm can experience fever and weight loss just because their cells are turning over more frequently and their metabolism is pushing. Also, as a result of this increased cell turnover is gout, and another condition called erythromelalgia, which I'll show you a little bit of a picture of now. But importantly, and why I've got this little graphic here, is that patients can complain of really a terrible itch, and it's got the unique characteristic of being exacerbated by having a bath. So if someone complains of itching after a bath, it's something to think of. Well, I'll do a hemoglobin level and see if you're polycythemic, and you'd have successfully solved a detective problem. They might also complain of feeling full easily after meals because of an enlarged spleen. So this is the characteristic faces in a pale skin, someone with a flushed and red face. This is the erythromelalgia, which is very painful red extremities. It can be in the fingers and the toes, which patients typically with polycythemia vera, rather than most causes of polycythemia, may experience. And this would be a gouty toe, this or gout. The first toe is frequently affected by gout, and any of these features should have warning bells and should raise the possibility of polycythemia vera. Okay, so I've now described absolute polycythemia and the primary version, where there's a mutation which can either be a congenital mutation or a mutation which may be a clonal malignant mutation which occurs as a somatic mutation in the bone marrow hemopoietic stem cell. And that would be the condition in which the red cell production is autonomous and not obeying signals. Now I'm briefly going to look at conditions in which that polycythemia is secondary. So it's an appropriate response. The red cell mass is responding to erythropoietin, and it's a response either to tissue being hypoxia or just having too much erythropoietin production for any particular reason. And erythropoietin is extremely important because with the testing and troubleshooting of a raised hemoglobin level, the next critical valuable test would be an erythropoietin level. If it was normal or raised, you would consider secondary causes of polycythemia. If it's suppressed, it's highly suggestive of a primary cause of polycythemia because it's the production of those red cells is independent of erythropoietin. It's actually trying to get itself out of the equation. So the hypoxia response, and that's the one that we all are aware of when we're looking at a patient who's got a raised hemoglobin level, and that would be with cardiac and pulmonary disease. Some of the highest hemoglobin levels and the highest EPO levels that we can get are with cyanotic congenital cardiac conditions. And pulmonary disease, there are a wide variety of pulmonary diseases that result in a degree of hypoxia. So all my colleagues who are up on the Highveld are relatively polycythemic in comparison to people down the coast, because the high altitude stimulates a higher level of red cell production, and so that's why we've got the different reference ranges based on altitude. We compensate, and that's why our rugby players at altitude would have an advantage potentially over people that practice at the coast. This becomes more marked the higher you go. Something that can be forgotten is local hypoxia resulting from localized poor renal blood flow. So this would be a case where if you had to do oxygen saturation, it would seem normal, it would appear normal. However, the kidney is hypoxic and erythropoietin is being produced as a result of that. Smoking, again, for a variety of reasons, causes hypoxia, partially by resulting in increased levels of carbon monoxide, and also by damage to the lung and potentially causing a hypoxia because of that. So a functional tissue hypoxia, and this is a case where your oxygen saturation would actually be normal, but carbon monoxide causes hemoglobin to hang on to its oxygen rather than delivering it to the tissues. And this is the same situation as occurs with certain people who have high affinity hemoglobin. So these are hemoglobins that hang on to their oxygen. So the hemoglobin's got oxygen. When it gets to the tissue, and there should be a gradient of oxygen moving into the tissue, it doesn't move so easily. So relatively, the tissue is hypoxic. So what happens in the renal cells? They produce more hemoglobin to compensate. So the same situation with the oxygen dissociation curve shifting happens with carbon monoxide poisoning. Just little illustrations of various causes. I mentioned localized renal hypoxia. This is a renal artery stenosis. Here you can see here's a renal artery which has got a plaque in it, an atherosclerotic plaque, narrowing. So less blood is going to the kidney. That kidney is hypoxic and will produce signals. This is obstructive. This is illustrating obstructive sleep apnea, which is one of the respiratory causes of polycythemia. And this would be a normal airway, which is open. With apnea, obviously the tongue falls back, closes the airway, and this sort of patient would be hypoxic, but the hypoxia would occur while sleeping. So it would be something that wouldn't necessarily be picked up during the day, but would be important to get a history of snoring or poor sleep, or situations that might suggest obstructive sleep apnea. This little visual is a characteristic of a little child with a congenital cyanotic cardiac condition. You can see the tiredness, the cyanotic peripheries, the toes, the blue mouth, and that's a very, very characteristic picture of a little kiddie who might have a defect. So that would be the situation where it was an appropriate response to hypoxia or decreased oxygen delivery. Then there are situations in which the body can produce erythropoietin autonomously, and that can be in the situation of a paraneoplastic syndrome and tumor related. The very classical condition is renal cell carcinoma, where you can actually have a high hemoglobin level as opposed to an anemia, which one would expect. Hepatocellular carcinoma is another tumor that can produce erythropoietin autonomously as a paraneoplastic component and result in polycythemia. An interesting one to remember, which is non-malignance, is a fibroid uterus. So this is a uterus with lots of fibroids, and a situation which you consider this would be a patient who complains of menorrhagia, but actually has really maintained hemoglobin level. And fibroids are benign tumours that can produce more erythropoietin, and it's something to consider when you've got a differential for polycythemia. Again, not to be forgotten, and you can see this little cartoon of a doping bike, is be suspicious in your patients who are athletes, who are gym bunnies, because blood doping, taking exogenous EPO and androgens and anabolic steroids can result in polycythemia. And we not infrequently get bone marrow investigations on patients, and our medical officers who actually taking the bone marrow do quite a thorough history and get the history that he's a mixed martial arts expert and did use testosterone at some point. So it is surprising what people do use, and also a very satisfying detective work. So this is a slide that I really would like everyone to concentrate on. We've described the mechanisms, but this is an approach to investigating polycythemia and what you would do on your initial assessment. Obviously, as emphasized, you want a full history and clinical exam. And that's on our full blood count, we will make the diagnosis of polycythemia. But very, very importantly, just make certain that there's no artifactual increase in hemoglobin. So this is different to a relative increase. This is related to pre-analytical variables, which can cause an erroneous assessment of a raised hemoglobin level. So if when the blood is being taken, there's been prolonged venous stasis. So the tourniquet has been put on and the patient and the difficulty finding the vein, and you're trying to hunt around for the vein. If you take a hemoglobin level under those circumstances, it can be artifactually raised. A clue to that would be an artifactually raised albumin. So something to think about when troubleshooting a raised hemoglobin level. The other consideration is that there's been poor sample mixing. So when EDTA tubes are taken, the draw order should be that the EDTA tube, which is used for an FBC, should be drawn first. And immediately after it's taken, that tube should be inverted several times. In the old literature, there's up to 25, so that's quite a significant amount of times. But we usually advise about 8 inversions, jerky movements, inverting that tube. Because if there's poor sample mixing and the sample isn't homogeneous, what you can get is pockets of raised hemoglobin level and an erroneous polycythemia. And I've highlighted microtainers here. Because microtainers are really like almost point of care tests, we can't mount them in a hematology analyzer as part of the general carousel and rack. When we use when the hemoglobin is analyzed, normally with a big EDTA tube, they're all stacked into a carousel, and what happens is that carousel within the machine is agitated and inverted to try and mix that sample up so that sample is adequately mixed. With a microtainer, you don't go through the carousel, you go immediately and sample the hemoglobin level. So if you haven't inverted that test tube properly, it could be inadequately mixed and you could get an erroneous polycythemia. Also, the problem with microtainers is that often if in babies or there can be a difficult bleed, blood is drawn into a syringe first and then put into the microtainer, and there's no knowing what happened in that syringe, if there were problems with the mixing within the syringe before it came before it was actually pushed into that microtainer. Again, overfilled samples won't be able to be mixed properly and can be another erroneous or artifactual cause of a raised hemoglobin level. And just basically samples where a patient's very lipemic or hyperglobulinemia is another cause for an artifactual or false raised hemoglobin level. So just to troubleshoot when you've received a hemoglobin level that's up and you really didn't expect it, always remember, just make certain that all these thoughts have gone through your head. And before you rush to the patient and say, oh my word, I think you've got polycythemia vera, we're going to need to do a bone marrow, there is a process that you would go through. Obviously, if relative polycythemia is suspected, so because of a reduction in plasma volume, this sample FBC should be repeated after the patient's been rehydrated or diuretics have been reduced or various other ways to combat that. Okay, so when you're looking at polycythemia, the cause should be determined, and the investigations are going to be largely directed by the clinical features. Obviously, pulse oximetry is non-invasive, easy, something that should be done on all patients, and critical is this erythropoietin level, because that's going to steer you in a direction towards, is this primary polycythemia or is this secondary polycythemia? The other tests, U and E, is going to help with assessing for dehydration, LFT, potentially any space-occupying lesions might become apparent, looking in the urine to make sure there's no hematuria, a sign of renal cell carcinoma. And something again that will be mentioned by Dr. Moodley is a carboxyhemoglobin assessment if you have a suspicion that the patient might have carbon monoxide poisoning or higher levels of carbon monoxide, and that's causing a shift in the oxygenation or the oxygen dissociation curve of hemoglobin and resulting in polycythemia on that basis. In the situation where there's suspicion for polycythemia vera, clonal polycythemia, PCR for the specific mutation JAK2 can be requested. And as I said, in P. vera, 97% of patients with the malignancy actually have this mutation. So it's a very high positive yield and a useful investigation. And you can tell the patient if it's positive and you've got polycythemia that it's very likely that they have got polycythemia vera. If it's negative, we do have the capacity to look at other JAK2 mutations or do a full myeloid next generation sequencing that will enable us to pick up other abnormalities which can cause polycythemia. I want to mention here is that JAK2 mutation isn't only seen in the setting of polycythemia vera, but it's also seen in 2 other myeloproliferative neoplasms. But they have got a lesser degree of positivity for JAK2 mutations than P. vera. But obviously the counts and the marrow features are going to assist the hematologist in differentiating. But P. vera itself is primarily a disorder of a mutant JAK2, either the V617F or other JAK2 mutations. So if polycythemia and JAK2, think polycythemia vera. Obviously, if your EPO is raised or normal and you're wanting to look at secondary causes, you might do an echo, chest X-ray definitely, look at the abdomen. Firstly, you can see if there's splenomegaly, but you could see if there's renal masses, renal cysts, polycystic kidneys, other things associated with polycythemia. And you might be required to do pulse oximetry to monitor for sleep apnea. Some patients will need a bone marrow investigation. I have alluded to some of these changes already, but things that would make you think more likely a malignancy, a clone, there would be the clinical features, the itchiness, the gout, and the erythromelalgia, those very painful extremities that I was describing. A splenomegaly would also be a feature that would be more typical of clonal polycythemia. The FBC, if the platelet count and neutrophils are also up, more suggestive of P. vera. The EOs can be, and basophils can also be increased. And on the peripheral smear, we can see these little red cells that look like tears. The marrow is crying, which is always a good indication that there's marrow fibrosis, which is something that we associate with the myeloproliferative disorders. So that's an important clue too. Usually a low erythropoietin level, and there will be characteristic marrow findings and a JAK2 mutation. So how do these patients do if they have got the malignant form of polycythemia? There's usually 2 phases. They start off with a very high red cell mass, and then what happens is the marrow goes on to becoming extremely fibrosed. The spleen grows in size, and often during this period, the hemoglobin level actually starts to drop. So that's the normal and natural history of polycythemia. There is a percentage of patients that can go on to transform or to an acute leukemia or to a myelodysplastic syndrome, and the high risk patients are more likely to transform. The patients, the prognosis of patients, the most important prognostic features is age. So older patients doing worse, but a high leukocytosis or a high white cell count of greater than 15 is a negative prognostic feature. If the patient has had a venous thrombosis at any site, that's counted as a negative prognosis. and if their karyotype's actually abnormal, and if they've got additional genetic mutations. So the backbone of treatment for P. vera is bloodletting or phlebotomy. I'm taking off the extra red cell mass. It's scheduled and targeted, and the target for the hematocrit is 45%. So you're aiming to get below that. In certain situations, like pregnant patients, you might aim lower, but this is an accepted level. And all these patients who have P. vera should be on daily low-dose aspirin. In addition, you can reduce red cells and white cells by using cytoreductive agents. And this is all high-risk patients who've got negative prognostic factors. We would use things like Hydrea and interferon alpha in younger patients. Any patient who has venous thrombosis should be on systemic anticoagulation. And then there are certain treatments like JAK2 inhibitors and interferon for patients who are not responding to Hydrea. Historically, there was fear that hydroxyurea would be carcinogenic and increase the risk of transformation, but so far that hasn't really been borne out in good studies. So it's still a really good drug for managing the polycythemia vera. And then just briefly, I just wanted to draw your attention to this publication, which is the British Journal of Haematology Guidelines from the Society, the British Society of Haematology for Management of P. vera and Secondary Erythrocytosis, because one size does not fit all. Because you've got a raised hemoglobin level, not all these causes indicate that you need to venesect the patient. Certainly P. vera does, but certain of the other ones, it's actually not indicated. And in particular ones like patients with cardiac conditions, any venesection should be done with great care and with a cardiologist and under a cardiologist's direction, because these patients have compromised cardiovascular systems. But one of the common disorders would be hypoxic pulmonary disease, and really what should be targeted is long-term oxygen therapy to reduce the hypoxia. That will naturally bring down the red cell count. But if the patient has hyperviscosity or hematocrit over 0.56, there's grade 2C evidence that this should be reduced to low 0.5. And there are a number of different scenarios that are managed by these guidelines, including congenital polycythemias, how to handle them, patients who are pregnant, how to handle that situation. But do remember that one particular treatment doesn't apply to all cases. These are just, that's the body of my talk. And obviously just would like to acknowledge Dr. Tricia Woodley for encouraging us and putting us all on the spot to do this presentation. And thanks very much, Tricia, and our excellent marketing department and digital marketing, these guys that have been working behind the scene to make sure that the presentation goes off smoothly. Members of my own department, Dr. Mnaru for providing me with the photographs that were present on this case. So, and this is a list of my references for anyone who would like to do a little bit more in-depth looking into the topic of polycythemia. Thanks very much.
She obtained her bachelor's in medicine from the University of Pretoria and subsequently completed her internship and community service at Chris Hani Baragwanath Hospital, and worked in private practice as a general practitioner before deciding to specialize in clinical pathology at the National Health Laboratory Services in Tshwane, University of Pretoria. Her journey at Lancet Laboratories started in 2015 in the hematology department, and now in 2022, as I mentioned, she's given up her life in Johannesburg to be part of the community of the Eastern Cape and has brought on this very exciting adventure to bring Lancet Laboratories to the Greater Eastern Cape region, with the support, obviously, of their head office team and colleagues in the other provinces. I'd like us just to put our warm hands around for Dr. Trisha Moodley. Thank you.
Louder. Okay. Just to say thank you to Dr. Holland for also sharing her time with us, and I hope you enjoyed that presentation. Okay, so we can go to the next slide, please. Thank you. Yeah, so this is just an introduction to our website, just to show you that we are quite well versed, and we have a great team of scientists and pathologists who are very active in academia as well. They do have, can we dim the lights here? Yeah, so they're quite involved in conferences, presentations, and publications. So just to show you that we are also part of the academic world. And yeah, so last year we published our article, secondary polycythemia due to carbon monoxide poisoning. Yeah, so this was actually quite an interesting finding, and we thought it appropriate to share this with you. As Dr. Holland explained, the clonal malignant side of polycythemia. So I'm just going to discuss with you the secondary polycythemia due to another cause, very unusual cause that we discovered. And yeah, so when you're working up a polycythemia, as Dr. Holland explained, it's quite tricky. And if you follow a procedure, you will be able to discover what the issue is with the patient. A good history is important, as she discussed, and also thinking outside of the box when investigating these patients. Okay, so if we can go on to the next slide. Thank you. So with our publication, what we did find is that these patients actually were a young group of patients. We know this is a growing trend, hookah pipe smoking. It's called by different names, shisha, water pipe. And it's a growing trend amongst all age groups, youngest being in grade 8 students. And yeah, it's quite interesting because it's not a regulated, like with cigarettes, it's regulated by the tobacco board. This isn't. So you have various apparatus that are not manufactured with standards. You have various products, tobacco products that are not regulated by the tobacco board. So anything and everything goes into these things that form part of the whole smoking. So what we have found, it is a ritual. People like to gather in places, in cafes, with friends and family, and smoke it. And what we have seen it is becoming a growing public health concern. And yeah, so we just thought it would be nice to bring this to your attention as well. Okay, so we can move to the next slide. Thanks. Okay, so from our discovery, we had a cohort of about 7 patients, all young male patients, and we discovered these patients based on the history that we took. They were age groups, late 20s, early 30s, and the most interesting findings were that the presentation of thromboembolic events. So we had one patient presenting with pulmonary emboli, and then another patient presenting with DVTs. Interesting in this is because, as Dr. Holland explained, is that this is a hypoxic event. The polycythemia develops, and also the thromboembolic events occur because of platelet activation. And the this is an interesting finding that we also saw. Okay, so from our findings, what we did discover is that you could actually calculate the patient's hookah pipe pachyia. And this was based on the frequency of their smoking, with how daily it was, the duration of the smoking, and how long they have been smoking for. And based on this very alarming figures we came across is that in a smoking session, it can equate to very large numbers of cigarettes and also a pachyia history, which is very concerning in terms of health issues. Okay, we can move to the next one. Thank you. Okay, so in terms of the laboratory investigations, this is very interesting. So Dr. Holland did discuss this as well. So interesting findings here were the raised red cell count, hemoglobin levels, hematocrit levels, and normal platelet counts. What we did find interesting was the carboxyhemoglobin levels. So importantly, to measure the pulse oximetry and also to do a blood gas analysis. So as part of the blood gas analysis, what we did discover was some patients had toxic levels of carbon monoxide poisoning, but still functioning normally because they had become used to this level of hypoxia. Next slide. Thank you. So just to illustrate your blood gas analysis. So your co-oximetry does give you a lot of information. Measuring your co-oximetry, you look at your total hemoglobin, your oxyhemoglobin, your carboxyhemoglobin, methemoglobin, deoxyhemoglobin, and then your oxygen saturation as well. In terms of your oxygen dissociation curve, so a raised carboxyhemoglobin will cause your oxygen dissociation curve to shift to the left, meaning that your oxygen binds tightly to your carboxyhemoglobin binds tightly to your hemoglobin molecule, so making it more difficult to release the oxygen. So in terms of that, what actually does happen, the body reaches a hypoxic level, and that results in mitochondrial damage at a cellular level. And this also leads to the symptoms that the patients present with, myocardial symptoms as well as neurological symptoms. So when patients present with these symptoms, they're very random symptoms, very nonspecific, but also just taking a good history would help you explain what is going on with them. Okay, so just to confirm what these patients did present with, the thromboembolic events, we did radiological investigations, the CT scan confirming pulmonary thromboemboli, and the other patient positive for DVT on his venous Doppler. Okay, next slide. Okay, so hookah pipe smoking, as we found out from our literature review, there are some very interesting non-hematological manifestations. People become addicted to nicotine. They become exposed to many carcinogens. In the tobacco, you don't actually know what is in the tobacco itself, so it's very high risk. The other pertinent thing that you are exposed to is infection. We have had one patient who actually caught COVID from sharing a hookah pipe. Wasn't documented, but it was anecdotal. You're exposed to other herpes viruses. Within the bowl of the apparatus, you have water. So the water is supposedly to filter the smoke. But if it's not changed often enough, you can have fungal growth, you can have mycobacterial growth. So it is quite high infection risk. Okay, next slide, please. Thanks. Okay. So what we've been through and what Dr. Holland explained is quite an interesting phenomenon. And history taking is always important, as you know, as clinicians. And to get to the bottom of anything, you need to ask the right questions. You need to look at your smoking history, what type of smoking. We see a lot of people smoking, vaping now. Hookah pipe smoking is becoming quite popular. Along with that hookah pipe smoking, people also smoke cigarettes, so you need to ask them about those as well. The other teaching points, if patients present with any thromboembolic events, part of the workup you would need to focus on that. Oh, one more slide back. Okay, and then your blood gas analysis is quite important. Yeah, so if you understand how to read your blood gas, it will help you. And yeah, so what the other important teaching point is that we actually need to try and make your patients more aware about the tobacco that's being used in hookah pipes. And yeah, so it's more of awareness and making sure that people are more health conscious. Yes. Okay. Thank you. This is my very short presentation, but just to show you the other side of an approach to polycythemia. It's quite a diverse subject, and yeah, so if you need any assistance at any time, you're welcome to ask. So yeah, and I just wanted to say thank you to everybody. Thank you.
No questions.
Okay, we can carry on.
Thank you very much, Dr. Mudli. Okay, thank you for tonight, and this brings us to the close of the formal proceedings, ladies and gentlemen. As mentioned, we are quite appreciative that you took the time out tonight to come and join us. I hope the exercise was well worth it on your evenings that are precious, as mentioned. There will be CPD points that are offered for tonight. Just ensure that outside you have completed your details. And for your colleagues and peers that didn't pitch up today, please do let them know. Yes, we forgive them. There will be a recorded session available on our website. If you visit www.lancet.co.za, the CPD for today will be available as points. But just in closing, I'd like to thank you very much. There is a light meal that is being prepared outside. Thank you for your time. In true Lancet style and as part of our values, Lancet Lab Siyakhathala, Lancet Lab cares. We thank the Eastern Cape Province. We thank Mthatha for the support. As mentioned, you'll be seeing a lot of us, and we are here to provide that service. Thank you very much.